ahead, and I am going to also do a little, I can't see my screen. So if anyone's watching, you're going to see my head in your screen right there. We're going to get started in just a moment. And Josh is just
That
going to be,
stream is not coming through yet.
is it coming through?
Nope. We're still
Okay, here we
getting the Connect streaming software to go live.
I can't see. This is so
Say, I
frustrating.
can try and block out the sun.
Can you block out? Ooh, look at
How's that? Is
you.
that any better?
Oh,
Sunshine
it's
blocker. I
good.
love
It's
it.
good.
We are all good.
It is good. You have connected.
Oh, fantastic. Hi, everyone. We're having just some connectivity issues a few minutes ago. And so I think we're live now. And I want to start. This is Dr. Devin Zarkowsky. You're with California. You're in an office-based lab now.
I am.
And
Yeah.
what's it called?
California Vascular Health Specialists. We're up in Fallbrook.
That's fantastic. You know, when I first met Dr. Zarkowsky, he was in Colorado.
That's right.
And then he moved out to California. He was working for a big hospital system. And what made you decide to go from the hospital system to an office-based lab?
Yeah. Listen, Kim, this is the fundamental question about vascular disease that is confronting patients and doctors. And it's the idea that access to care is a real challenge for
Yeah.
folks that can't walk.
Yeah.
And so what I notice is that the majority of my patients in the area were coming from outlying regions, not La Jolla, not San Diego, but El Cajon, um, Rancho San Diego, Fallbrook, Temecula. And, these folks would tell me every time I saw them, do I really have to come down to the city? Do I really have to go to, major hospital? Do I really have to go to even minor hospital?
Yeah.
And I said, well, this is where I am. And I would give them the company line, but it wasn't satisfying. And I found that people wouldn't come back because of the challenge of getting to somebody to take care of their legs. And that's really what made the decision for me is I'm fundamentally here to be a doctor and take care of people and be useful. And if I'm not where I am needed, then I'm not useful.
What is the difference for people who don't know? We were just talking about this actually before the live stream started. What is the difference between being treated in a hospital versus an office-based lab? And then also the third is the ambulatory surgical center or ASC.
Sure. I think an ambulatory surgery center is a very similar environment to an OBL. There's a layer of complexity when it comes to regulation that an ASC has added to it. But both are similar in the sense that it's a more personal touch than a system. And that's really what is important to me is that when I see a patient, they're coming to see me to be their doctor. That's the experience that's gratifying for me, especially when I can help somebody. And so from a satisfaction standpoint for quality of care, for me as the doctor, I much rather you come to see me rather than hospital system. I think for the patient, what I got in talking to people is the challenge of navigating, major hospital or even minor hospital, the difficulty associated with getting somebody on the phone. And so something that I do for my patients is I give them my cell phone. I have my phone, I'm sure will go off. It'll buzz in my pocket. One of my patients will be calling me with a question. And the reason I do that is because there's 11 layers of protection between me and the patient when I'm in a system versus, a text message or a phone call that really takes me 30 seconds to answer a question. And so I think for a patient, that is the real difference between coming to an office-based lab or an OBL or an ASC type of setup.
And it's interesting. I'm going to ask him a really loaded question because there's so much controversy around the office-based labs these days. There was a New York Times article that came out. There were some ProPublica articles that came out where they were talking about overutilization of tools for, monetary reasons at some of the office-based labs. And there were a lot of, quite a few OBLs that went out of business because of this controversy. There were some issues with the referring centers like primary care and podiatry not wanting to refer. You have done this literally right in the thick of the controversy. How difficult was it for you in making that decision? And what hurdles did you have to overcome in order to get this office-based lab opened up?
Sure. In all walks of life, you find people who make good decisions. You find people who make bad decisions. It's not something that's particular to office-based lab versus hospital system. It happens in politics. It happens in law.
Yeah.
And what we need to remember as doctors, as patients, is it's the person taking care of you and the quality of their care that matters, not the setting, not the type of place that you go to. And really understanding that there are many factors that go to taking care of a leg that has vascular disease that don't necessarily relate to where it's done.
Yeah.
And that's never going to change. I mean, there can be as many articles written about setting of care as there are newspapers in the country, yet the fundamental factor will come down to, is the doctor capable of taking care of the patient, not where the patient is taken care of.
And I think it comes down to you as the patient taking charge of your care and understanding that there is a fundamental difference between the different types of PAD and the care you should receive and what are the standard practices. And I'd like to go through those because there is a serious determination. There are intermittent claudicants. That's the early stage of PAD. Well, you have asymptomatic, right? No symptoms. Then you have the intermittent claudicants. These are the early stage people where conservative treatment is the best. It's medicine and it's walking. You always hear that walking's the best medicine. And then there's the next phase. You have the lifestyle limiting claudication. And then you have the advanced stage, critical limb ischemia, CLI, or critical limb threatening ischemia. Would you mind just walking us through in a very simple form, how a patient can tell whether or not they should be receiving a procedure to open up their arteries mechanically, whether it's through, endovascular, which is wires and balloons, possibly some stents, even some roto-rooting devices, or even surgical bypasses, endarterectomy where they scrape out the plaque, right? How does a patient know what they need?
Okay. This is the most controversial topic
Yes.
in cardiovascular treatment.
We didn't know what you were getting into.
Right, yeah. So I'm going to turn your question on its head, Kim. We're going to answer the easy questions first.
Okay.
I'm going to start at the end of the spectrum, the chronic limb-threatening ischemia patient, CLTI. CLTI is the end stage of vascular disease. It's when you have a limb with ulcers, either on the toes or on the ankles, that is caused by lack of blood flow. This is a situation where seeing a vascular specialist is critically important. These folks run the risk of major amputation, and it's not small. It can be 25% per year. And that's the number that came out of the most recent clinical trial called BEST CLI, which was published in the New England Journal of Medicine in November 2022. The other folks in this category of patient are the folks with rest pain. And those are the folks sitting on their couch that say, oh man, my foot hurts. And it's not leg, it's not thigh, it's not buttock. It's usually almost exclusively foot. That is really the hallmark of chronic limb-threatening ischemia in the leg. This is another sort of person, maybe doesn't have 25% per year risk of major amputation, but it's high. It's 10 to 25%. It's in that range. Those are two groups of people who really should see a vascular specialist, whether it's a surgeon, cardiologist, interventional radiologist, whoever is serving your community, to take control of their peripheral arterial disease. It's a must. That's an easy question. The question of what to do, well, BEST CLI is a challenging study to analyze.
Yes.
The difference between open surgery and minimally invasive surgery is very tight. It was percentage point differences. And so as a vascular surgeon, it doesn't affect my practice so much. There are people in this category of patient that I treat minimally invasively. There are people that I treat with open surgery. I have both types of patients come to see me on a regular basis, and I offer both sorts of care up in Fallbrook. I think for folks in areas where there's only a cardiovascular specialist that can do minimally invasive work, it becomes a bit more challenging of a question to answer is, which should you do? I think the fundamentally important thing is that people see a doctor and even ask that question, because there are so many people that I've seen up in Fallbrook recently who have never seen a vascular specialist.
I think that's the bigger deal.
And they get, a toe amputated for one reason or another, and it doesn't heal.
Yeah.
And then they're really at risk for a major amputation, either below the knee or above the knee. And that's the whole reason we're doing what we do. You're doing what we do, and I'm doing what I do.
Yeah.
So to get into the weeds on which is best, I think is beyond the scope of our discussion. I really think that I encourage people in those two categories, wounds on your foot, pain in your foot, go see somebody.
Yep.
Then we can have the conversation.
And we always tell people to get a second opinion, and actually different doctors, different philosophies, different facilities, you might have different options available for you. And we really try to say, hey, less is more approach, and encourage the doctor, less is more, above and beyond. And if you are going to do endovascular, you probably would agree, you know what, less is more, kiss it with a balloon, try and cause less trauma is actually better.
That is 100% correct.
Yeah.
You're exactly right.
We still have a lot of doctors in some of the outskirts areas where it doesn't seem like the doctors may attend some of the advanced conferences that you and I have attended. We just got back from a conference last week. It was so great to see you over at that conference where they were talking about some of the new tools and techniques being used, particularly in some of the office-based labs. But the less is more is consistent with even the stenting. And we still have patients where the doctors are saying, you know, we're going to do a procedure and we're going to stent. But that's a little bit old school, unless you're talking about the iliacs, the abdomen, or even the heart. You actually are adopting more of a philosophy like leave nothing behind if possible, right?
That is true. That is one of the major concepts that a lot of companies are really pursuing nowadays. The idea that you can put in a stent and have it last for 20 years, I think, is something that's falling by the wayside. A lot of treatment involves making sure that the tissue that was there functions unobstructed by a foreign body.
Yeah.
So there was a huge controversy about drug-coated balloons that I'm sure you're well aware of, going back to 2018. That has kind of calmed down, and now we're back using drug-coated balloons. There's other things. PQ bypass is something that folks have been using to route a stent through the vein so that it doesn't use arterial real estate to bypass a blockage. And then there are other things like reabsorbable stents. I think actually yesterday, there was FDA approval of one of the stents
from Abbott.
Sale. Yes. A company performed a very good clinical trial that was presented, I think, in October at Viva, showing that it did better than just a balloon that was uncoated below the knee. And so it's another option that's coming for patients to ensure that your own tissue is really what persists for the lifespan of your treatment.
Can you, because for folks that don't understand, so you have the plain old balloon. The balloons are used to dilate the vessel. So they go in with a wire, they slip a balloon over the wire in an endovascular or minimally invasive way, just a little puncture right in your thigh, or in your groin, or in your foot, or wherever they're going to puncture to access your artery. And then they inflate the balloon to push that plaque aside, whatever type of plaque. And you have the plain old balloons, but then you have ones that have a drug on them. Can you talk a little bit about the difference between the two and why a doctor would use those drugs?
Sure. The drugs on the balloons are useful in many different areas of medicine. The drugs in these particular balloons prevent cells that cause the occlusions to form from continuing to grow. And the thinking is, if you have this drug present for a period of time after you treat the patient, it prevents the inflammatory process from going out of control and causing the artery to have an injury that then reoccludes blood flow. And it's been proven above the knee, and it seems now below the knee with this new stent to do just that. And so everybody's very excited about this option.
Can you talk about the bioabsorbable stent? We did have a question that came in from Alan just a little earlier today where he was asking, why is it, and you alluded to that a little bit in the beginning, but why is it that Europe has been able to use these drug-coated balloons, and especially below the knee, and the US has not, or they're just now getting these to become available?
Sure. Having been through the process of submitting things to the FDA for multiple reasons, I can tell you that the FDA is a tough customer. The amount of...
It's a good thing, though.
It's a good thing.
Yeah.
The amount of scrutiny that they put into regulating devices is far more extensive than Europe. And so when companies look to sell their product, it is common for them to go to Europe first to receive what's called a CE mark through the European Commission. and go to market far years, sometimes decades before the United States. I'm thinking of a particular device that's involved in aneurysm care that's been available in Europe for going on 15 years, but is not sold in the United States to every vascular surgeon. It's only available at about 10 centers around the country.
Wow.
And it has to do with some of the details of the regulatory environment in the United States versus Europe. And so that's the reason that below the knee stents are not as common in the United States. Having said that, you as a physician can put in stents as an off-label use, and coronary stents are very often used for that purpose.
Yeah, I've seen that.
So I can tell you that despite the terminology off-label use, there is still a high degree of safety for using stents below the knee in the United States. There becomes a bit of a challenge from a medical legal standpoint. However, it is safe, it is effective, and it is widely done in the United States, but just not in an on-label sense.
And talk about the bioabsorbable stents. What are those and why are they different?
So bioabsorbable refers to the body being able to break down the material that is deployed by the physician. The exact composition of the Life BTK stent, I think, is still proprietary. And so I can't tell you too much about the structural details of that. What I will say is that it is encoded with drug as well. I think it's everolimus is the name.
Which is a cancer drug.
Yeah, that is true. And that everolimus has a proprietary way of being affixed to the bioabsorbable stent, and then slowly it's released over time, allowing for treatment of the peripheral arterial disease below the knee.
And we have a Dr. Gupta. We had mentioned that the bioabsorbable stent was supposedly going to be available very soon. And it was just approved the FDA. And he brought up a good point that there's another device. It's called SPUR, SPUR, which he was saying that, you know what, I don't know, maybe use that, maybe use the SPUR instead. And that's the stent that has the thorns on it that you can actually leave in for about 6 minutes and then you take it out, and it's by reflow.
So that's interesting. I don't know about SPUR. I know about Serenator. What you're describing is a very similar device to the Serenator balloon that's Cavant. Peter Schneider is the inventor. He's actually one of my former faculty at UCSF. The SPUR I'm not familiar with, so you've given me some homework there.
No, this is a good point. I always talk to you that different doctors have different access to different tools at different times, especially when they're getting ready to come to market. They can't deploy a device out to every single person until it's actually approved. But even then, it's a slow process of rolling that out. And right now, this device, the SPUR, which is a stent, it has some thorns in it, in a sense that they call it a removable stent. It's available in Europe right now, but they're still in clinical trials. As Dr. Zarkowsky was mentioning, that it does take a little longer here sometimes to get to market with a more stringent FDA approval process. And they're not expecting that to be available until Q1 of next year. But right now it's available in a few sites who are part of the clinical trial. Not every doctor can be involved in every single clinical trial.
True.
Are there any trials that you are involved in, or you going to be involved in?
So my practice is a clinical focus right now. I am taking on patients alone. I have my own solo practice. Because I felt like all of the academic work I was doing in major hospitals was really changing my relationship with patients.
Yeah.
So this is kind of a soul project for a few years. I fully intend to go back to research and clinical trials, but for the moment, I really just want to focus on being a community doctor.
Yeah, I love your website. Really was amazing in just taking and offering that holistic approach to patients, which you don't always see. And I think it's so important, especially with PAD patients, that you do have the time to listen, because I know that every one of you that's on here right now is going to agree with me that the number one complaint that you have is doctors don't have time to spend with you. Doctors are getting interrupted by phone calls, they're involved in their notes, and they don't take the time to actually not only listen, but also touch the patient. And that's something that you've probably seen and experienced a big difference in since you've opened up your lab.
Yeah, absolutely. I think the one-to-one connection where you're talking to a person and you can hear their challenge with vascular disease is so important. And that's why I didn't answer your question about intermittent claudication first, because I think that's the one that really involves listening. And the thing that when you said that came to mind is a guy that I met a couple of years ago. He's 58. He had lived in Hawaii and he was a construction worker and couldn't walk up and down stairs at his job anymore and had to retire. And the doctor that he saw, you know, he told him the story about claudication, but this particular specialist didn't treat him. And he was forced into early retirement. And so when you mentioned intermittent claudication and the challenge of deciding whether or not to treat it, that's a situation where I treat intermittent claudication.
Mm-hmm.
If somebody is going to have to retire at 56, about 8-10 years before they want to, yes, I treat their claudication so they can continue to do their job.
And that's interesting that you say that, because, you know, in that big, you know, overall controversy surrounding the early treatment of PAD, in my network, I've seen so many patients that have had to retire because in their jobs, even a little cramping that gets in their way of doing that job, they have to go into retirement. And yes, they might be an intermittent claudicant, but it almost, you know, goes into that lifestyle limiting because it's career limiting. They can't do what they're normally doing on a daily basis to bring in the money, so they end up on disability. And that's very frustrating. So I think that you bring up a really good point, that's a very sticky situation, and it needs to be something that should be left up to the doctor and the patient themselves, and should be taken on a case by case basis.
That's absolutely correct. I think there are a lot of absolutists when it comes to claudication. Oh, never treat it, or oh, I always treat it. This is the shades of gray that comes along with the art of medicine. It's really understanding what the claudication means to the patient, not what the claudication means to the doctors that want to tell you how to treat it.
Yeah. So I want to open it up. We have quite a few people on here. I'm going to first start with Douglas. Douglas, he is our PAD warrior chief. Douglas, you have quite a few questions that have been coming in over the last couple of days. Do you want to open up and ask Dr. Zarkowsky?
Yes, Darlene had a question, and I think you had talked about this. She was wondering if there are dissolvable stents for the thigh.
Sure, Darlene, great question. That's been tried a number of times. The reason the Life BTK2 study was so groundbreaking was that the experience in the heart had really informed treatment for about 10-15 years before this study. What was found in the heart is that after implanting about 200,000 absorbable stents, the stents tended to occlude more rapidly than drug-coated stents. And so for that reason, enthusiasm for cardiac, heart-based reabsorbable stents and reabsorbable stents above the knee, it basically went away. The company's no longer invested in that space. And I'm not the most educated on this topic, but to my knowledge, there is no commercially available absorbable stent that will fit in a superficial femoral artery above the knee. Certainly, as of today, maybe Q4 of this year, we will have a below the knee stent from a company.
Yeah.
And Debbie had a bypass 6 years ago. She's getting cramps in her legs at rest. And I think it goes to the point, how often should we with PAD be checked yearly, or how often should we go back and have ABIs and all of that?
I mean, Debbie, this is a great question. And this goes to what Kim and I are talking about, the longitudinal relationship that cardiovascular specialists have with their patients. I don't want to give you medical advice because that would not be the appropriate thing to do for this forum. But the symptoms you're describing really suggest that the bypass should have an ultrasound. Ultimately, I think your question is how many times should that bypass be looked at per year? Really, in my practice, I see folks back about a week or two after surgery to have a look at their incision when I do a bypass. And then I may do an ultrasound depending on how far away they live. But generally, if they're close by and they don't mind coming back, I see them back a month after their surgery and I do an ultrasound. And then every 3 to 6 months for about 2 years. Really, I don't trust a bypass until about 2 years. And that's the moment in time when I think, well, if I haven't needed to do anything up to this point, We can probably go to every 6 months to every year, and I really leave it up to the patient to tell me what they feel comfortable with.
Yep. And a lot of what makes those bypasses more durable is lifestyle modifications and compliance with medicine.
That's true. And walking. As
Walking,
well.
lots
Yeah.
of walking.
Yeah, all of these
That's
things.
a perfect segue to one of the big questions that we have is walking. As we get older, we tend to slow down a little bit. But when we're building these collaterals as we get older, do we lose those collaterals, or do we have to continue to walk like we do today all the time?
The collaterals ebb and flow with your blood pressure. So if you're able to generate some demand by walking, your legs will route blood through those collaterals. They will expand a little bit, but when you stop, they'll contract a little bit. If you allow them to stay in that contracted state for a long period of time, yeah, they will start to diminish in size. And when you demand them to work again, they won't be as good as they were when you were walking. It's one of those aspects of getting older that's kind of unavoidable, unfortunately. But the more you push yourself, the better your collaterals will be for your life.
And I think that we should go to Vlad. Vlad, do you want to unmute and ask your question? I think you had one about exercise as well. I believe Vlad's on there and he can unmute. Vlad, go ahead and unmute.
It looks like we lost him.
Okay, so his question actually was right before you got here. Sorry, it's so hot out here. We're actually out in Carlsbad, California, Southern California, and we're out in the sunshine and we're both baking out here. I didn't expect it to be this hot. It was only supposed to be in the 60s today, so I thought, oh my goodness. And while I've been sitting out here, the sun just keeps beating down more and more on us. So if you start seeing us sweating, that's why. But we're at the Cape Ray Resort over here in the Carlsbad area, and your office isn't too far from here.
Yeah, it's
right?
about 10 miles.
Yeah, so not too bad. So this was a good meeting spot. But Vlad was asking about, it's a good day for exercise to get out and walk.
Absolutely.
But he was wondering, if his doctor had told him to walk. And I know there are a lot of studies on walking as medicine for PAD. Is there any other exercise that he or anyone else could be doing? We get asked about cycling and swimming, or is walking the only exercise that's going to help these patients?
No, great question, Kim. I think that's something that I've keyed in on as a verbiage. I'm trying to think of a better word, but verbiage is the one that comes to mind. The words you use really make a difference to the way patients understand what you've said.
Yeah.
When we say walking, that is really a synonym for any sort of activity that gets your legs moving. Swimming, biking, climbing, jogging, surfing. Those are activities that make your legs move, make the blood flow through your legs, and really have an impact on your ability to function when you have PAD.
Mm-hmm. So just get out there, move is really what's most important.
Check the mail,
go
to the mall.
Marcia has a couple of questions also.
Okay, Marcia, go ahead and unmute and ask Dr. Zarkowsky your questions.
Hi, I have two questions.
Okay.
One doesn't really apply to me, but I hear it on our forums a lot, and it's about statins. People who don't tolerate statins and they just quit taking them. Sometimes they tell their doctors, but probably mostly they don't. And so I'm curious what your feeling on that is. And my second question is, I get this feeling kind of often where it feels like I have an itch deep down on the inside of my leg. Like my bone is itching or my artery is itching. And I'm wondering if you've ever heard of that, or you might know what it is. That's my question.
Is this in the area where your stent is located?
It is, but I also, when I was pregnant, I had TUPS. I'm not sure if it's PUPPS. It stands for I don't know what it stands for, but it has to do with your, is it papillaries? It's allergic to being pregnant, basically. And I had it horribly then, but you itch all over when you have PUPPS. I had it horribly then, and it was in my legs. It was never really on my trunk. It was on my extremities, my peripherals. But I still get it. I had it today, where I just want to scratch my bone.
Yeah, Marcia, that really does sound frustrating. I'm sorry that you're having that trouble. Let me answer your second question first. There are many different things that affect the lower extremity from a vascular standpoint. California vascular health specialist, my practice, I make a particular point of paying attention to arteries, veins, and lymphatics. And those are the three vascular systems in the legs that I really can comment intelligently on. And I would say an ultrasound or an exam targeted at those three systems would be in your best interest, especially if you do have a stent in your leg. Certainly, if you were in the Fallbrook area, I'd be happy to help you out. But if you're far flung, I'm sure Kim has somebody that can take care of you. Going back to your first question about statins, there are a number of low-tech and high-tech solutions for folks that can't tolerate statins nowadays. Statins were first developed from red rice yeast. It is actually a natural product chemical that was extracted from the red rice yeast and created lovastatin. That was the first statin drug. The other option folks have is niacin. Niacin is a bit hard to tolerate because it's a big pill and it causes flushing, but it's another option that is effective in lowering cholesterol and helping with peripheral arterial disease. And those are the two low-tech solutions folks that don't tolerate statins have. The other high-tech option, and this is becoming more and more common, is something called Repatha. It is a PCSK9 inhibitor. It is very expensive. And having had to fill out a number of forms from insurance companies, I know that insurance companies do limit access to it because of the cost associated with it. Those are the three things that I think patients can pursue if they'd like to have something other than a statin for their peripheral arterial disease.
We just had a little friend join us. So this is Chardonnay, Shari.
Hi.
She just got here and just decided to jump on my lap. So I hope you don't mind. Douglas, do you want to jump in with
we have
some
another
other
question.
questions? Yep,
We
go ahead.
we can't see the doctor first. We can't see the doctor.
What
Okay.
about the itching? You didn't address that.
Again, with the itching, that's really a situation where I would examine you with an ultrasound, trying to figure out whether or not it might be a blood flow issue first, because there are vascular challenges that can cause itching. Venous troubles, that's the first one I'm thinking about. Vein disease can cause itching in the leg. And so that would be the first place I would go as a vascular specialist to have a look at your itching issue.
And so one of the questions was, in the beginning as a patient, how can we get with our doctors? Is it medicine first or procedure? Did that make sense?
That's a good question. Medicine first or procedure?
Sure, yeah. These things go hand in hand. Certainly, I would never recommend a procedure without a patient on appropriate medicines. In fact, that is a challenge I often have to go through and hold a patient's hand with. How do I get this medicine? Figuring out the preferred pharmacy, where to send the medicine, how to get the patient the medicine. That is part and parcel of doing the procedure, because you can't take care of a person with a procedure and not have them taking appropriate medicines.
And a lot of times, especially, we've talked a lot in this about the early stage PAD, the intermittent claudicants, and that's literally where, people are, you walk, you get a cramp, when you stop and rest, it goes away and you can walk again. That's really what they consider the intermittent claudicants, right? And so many insurance companies actually require that if you're in that stage, that you have to go through 3 months of conservative therapy to see if that improves your symptoms. And that includes taking certain medicines, and that could include aspirin, it could include an anticoagulant, it could include a statin or some other medications, coupled with smoking cessation, diet, and a regimented walking program.
Yes, regimented walking is something that has been clearly proven to help people with intermittent claudication, in addition to appropriate medicines and smoking cessation.
Yeah.
That leads us right into you nailed it, Kim. The importance of us stopping smoking, eating properly, and how it affects our PAD in our living.
lifestyle modifications and how important
Lifestyle
they are.
modifications.
Very important. Everything in moderation.
He likes that
Very simple.
question.
Yeah.
How often do you have that question
Yeah.
during the day where you're like, you know what, you need to stop smoking?
You know, I am a bit of a person that honors the autonomy of a patient. There are very few things that I can say that really prompt a response. One of those things is you need surgery. People have a very particular response to you need surgery.
Yeah.
And that tends to raise a lot of concern, appropriately so.
Mhm.
When folks have trouble changing their diet, stopping smoking, I'm happy to be an assistant in that process, but I can't make you do it. Similarly, I can't make you have surgery, but there are very clear and sometimes immediate consequences for not having surgery.
Yeah.
Whereas it's harder to conceive of the benefit from quitting smoking, especially since it's such an addictive process.
Yeah.
And so I fully respect the autonomy of people to say, yeah, it's not the moment.
But if you do have a procedure, it's, you know, if you haven't stopped smoking, it's just going to close back up sooner.
That is right. That is
Hey,
right.
we'll go. Nancy has a question.
Nancy,
Yep.
go ahead.
Hi, can you hear me?
Hi, Nancy.
Yes,
Hi,
we can hear you.
back from my walk. Hi. I have a question going back to Repatha. I'm allergic to statins. I've been on Repatha for a few years now, done very well with it. But of course, my cholesterol is not, my LDL is not as low as they want it. So my cardiologist and his physician assistant put me on Zetia, and they're watching it. I'm down to 70 with my LDL, but they want it even lower. So they're talking about a combination drug that's just out, and I was wondering if you've heard of it and if you could tell me anything about it. And my cholesterol is mainly through genetics. I've been up to now walking 16,000, 17,000 steps a day right now. I eat healthy. I'm fighting hard. But I'm interested in this drug, and I do get my Repatha through the Medical University of South Carolina free of charge. So I'm very blessed with that. You know, they were
Well,
able
that's
to work.
phenomenal.
Yeah.
Yeah, no, that's 7.5 miles a day. So congratulations. That's good walking.
Yeah.
In terms of the combination drug that you're describing, there are combination drugs with Zetia and Zocor. That is a drug that I'm familiar with. I'm not familiar with another Zetia, either statin or Repatha combination. So I would need to look up some more information before I could advise you on that. I would say, listen to your physicians. Certainly, they're getting you. You're more than on the right track. You're where you should be. Quite frankly, I think when it comes to an LDL of 70, it's hard for anybody to say there's better.
Yep.
You are hitting the U.S. Preventative Services Task Force guideline for cholesterol from version 8 of that document. So I would say that you're doing really well. Keep it up.
All right, thank you. And if I do get the name of it, can I let you know? But I don't think it's Zetia. She put me on Zetia. We're going to see the next blood test, and then they're going to think about moving me over. But something about the insurance won't cover it unless you first try Zetia first, and then go on to then they'll go on to this new combination drug. They're just coming out with it. So if I get the name,
I don't. I'm going to be blunt. I don't.
It's hard. I was just asking him in case you didn't hear. You see Bailey just showed up as well. I got the full animal farm here. Everyone knows Bailey. But I was under my breath. One of the issues that we're dealing with is that, a lot of insurance companies these days are overriding the doctors, and they're not the ones who went to medical school. Dr. Zarkowsky went to medical school, and sometimes, how frustrating. And he was just like, it is frustrating that when he wants to do something for a patient and thinks something is best for the patient, and the insurance company says, I'm not going to cover it. That's just, it just makes you frustrated. I can't think of a better word.
Yeah, quite frankly, I'm going to give a plug to our federal government. Medicare is by far the easiest insurance company to interact with. And I know it didn't always used to be that way, but I can't say enough good things about the way Medicare is run. So
yeah. Well, what's frustrating for me is that, this does run in my family, and I'm trying so hard, and it's like, no matter what I do, I can't get this cholesterol down, and it's frustrating, so, but I'm
wondering, in terms of your opinion on this, but when we were getting my dad first tested, and he ended up getting diagnosed with heart disease, he got a Boston Heart Diagnostics panel, which is an advanced panel of all kinds of different, factors in the blood. And what he discovered is that there's a basic lipid panel and then there's an advanced lipid panel. And the cardiologist told him that you can have a whole bunch of large fluffy LDL particles, but it's the small dense LDL particles, the ones that can become oxidated by the trans fats and the free radicals, that those are the ones that you have to worry about, but you don't know the balance of them until you get an advanced lipid panel. So he doesn't look at a basic lipid panel and care if you have a whole bunch of LDL just overall. He cares more about the quality of those LDLs.
Yeah, I think that makes good sense. I would agree with that statement. And so I tend not to manage in that detail often, but these small particles are the thing that binds together the larger particles in your blood vessel to create peripheral arterial disease. And so, yes, I agree with what you're saying.
And the second part of that, that my dad was actually told, is that he didn't have a liver production problem when it came to cholesterol. It turns out that he had a cholesterol reabsorption problem. And I'm just going to be frank, he wasn't pooping enough. And so for men, that you are supposed to be going like 2 to 3 times a day, especially when you have high cholesterol, to make sure to flush things out a lot quicker. I don't know the whole process, and I'm because I'm not a doctor, but it's supposed to be the HDLs carry the LDLs out of the body, something like that.
Yeah.
They're excreted through your body. So if you're having trouble getting cholesterol down, that could be an issue as well. It's why they say that you need high soluble fiber diets.
Fiber is always good. From my days as a general surgeon, when I was involved a little bit more with the colon than I wanted to be, yes, I would always recommend fiber.
We have a question come in from Alan. What do you think about some of the new procedures and appliances that are being used today? And where do you see, how do you get excited about the new procedures and new applications out there?
Yeah, so when patients still have challenges, that's when you know that there is always a need for innovation. I think of procedures that I did in general surgery. The one that I think about is the gallbladder. A laparoscopic cholecystectomy is as close to a perfect operation as exists today. It's safe. It is a day surgery. It doesn't need to be done in a hospital. It's reproducible, and it's done in all parts of the country, all parts of the world. It's cheap, and folks come back well from it. When we think about peripheral arterial disease, you have leg bypass, which is proven to work, but that's a 6-month commitment from a patient to get back to where they were the day that they walked into the hospital to have that surgery. We are working to make catheter-based technologies, and they are very close to as good as bypass. The thing that really becomes the gallbladder of peripheral arterial disease. And yes, there are a number of new procedures that will work toward achieving that goal, that folks can have this in all parts of the country without having to feel like they are without care.
But it's still evolving. I mean, it's actually exciting for you to be involved in this care at this particular time and being able to see all of the advances the companies are making.
Absolutely. Innovation is a hallmark of cardiovascular healthcare nowadays. It's one of the things that, one of the reasons that I part of this field is because of the opportunity to participate in the new. And yes, absolutely. That is an important part.
We have a question coming in from Rose. Go ahead.
Yeah, hi. I have a question. I'm not sure. One doctor told me I have PAD, the other one told me I had CAD. I just don't know what the difference kind of is, and I'm having this pain that I wanted to mention. It's in the middle of my chest, and it's kind of like a bubbly pain, and it kind of get me restless, and I can't sleep at night, and I don't know what it is.
Well, hi, Rose. Thanks for calling and coming to talk to us. Yeah, certainly The acronyms, they get to be very confusing. There's a lot of, letters that get strung together in medicine that patients
Mhm.
have challenges decoding. So to start with CAD, that's coronary artery disease. That's really a function of the arteries in your chest and your heart. That is the one that could be causing multiple different pain symptoms in the chest area, among other diagnoses. It's not the only one that causes the things that you're describing. So I would certainly go talk to your doctor about coronary artery disease and mention the discomfort that you're having. Then PAD, peripheral arterial disease. Classically, that refers to any artery that is not in the heart, but in modern days, we usually use it to refer to leg disease when we're talking about arteries. And so peripheral arterial disease, PAD, leg disease, that's found in folks that also have coronary artery disease. And I see both. I saw a gentleman yesterday in Fallbrook who had both coronary artery disease and peripheral arterial disease. So patients with one tend to have the other.
So the ones mine are in my neck, but he
Say
told
that
me I
again
had
for me,
PAD.
Rose.
Mine's are in my stenosis are in my neck.
Oh, so she has
Yeah.
carotid.
So that's carotid disease. That's carotid arteries. And yes, goes
But
hand in
he told
hand
me
with heart and
okay.
leg.
And Rose, do you have an
No.
appointment coming up with your doctor? Have they offered you treatment options sooner rather
Not
than later?
really. They just monitoring me for 6 months, and I just have so many questions that they didn't answer for me. That's, like right now I'm having this pain in my middle of my chest. It's like a bubbly feeling. Like I said, I don't know if I should go to the emergency room or not.
Well,
It's
certainly,
like
Rose, anybody that comes to California Vascular Health Specialists like Counsel, if they are feeling concerned, it's always best to go
Yep.
see a doctor sooner rather than later, whether that's the emergency department or your general physician. It's always better to talk about those concerns just so they're not bothering you. It'll help you sleep better.
And Rose, we do have our Lifesaver hotline. And Douglas or Josh can put that in the chat box if you can read the chat box. The Lifesaver hotline is 415-320-7138. That's 415-320-7138. And one of our navigators can actually get on the phone with you and help you to facilitate getting to a doctor soonest who's nearest you. And we can even help advocate for you if you do decide to go to the emergency room. We can actually be on the phone with you during that appointment to make sure that you are getting heard and you are getting the treatment and that you need.
Oh, okay.
Okay.
What a great service, Kim. I'm so glad that you do that.
Now, I have this. Does the CAD also when you have CAD? Because I feel nothing in my legs really, but is
That's
that
okay.
together?
That's
That
okay.
together,
We can,
that's gonna happen.
yeah, go ahead and in the chat, you can go ahead and type in. I don't want to do this live over the broadcast, but
Okay.
you can go
Okay.
ahead and even put your phone number in the chat. And Douglas can get that for me, and I can give you a call after this.
Okay.
I have
Okay.
advocated for my dad as well with his heart disease,
Okay.
and I'm happy to help advocate for you as well and help you to get the questions that you have answered by your physician.
All right. Perfect. Thank you so much.
Of course, anytime.
I
Do
have
we
a
have any
question.
other questions?
I
Yes,
have a
go ahead,
question
Douglas.
about
Yes.
bypass. I wanted to ask a question about axillary bifemoral bypass. Do you believe that can lead to CAD, or because I'm having trouble with my bypass, with my graft is completely blocked, and it pokes me, and every time it's doing that, it causes my heart to act strange. I was wondering what you thought about that.
Well, I say that in medicine, there's never a certainty. I can never be 100% sure about anything. That's how you know a doctor's lying. I can only ever be 99% certain. In your scenario, I would really have to know more detail about your health history and your anatomy. It would be unusual for a bypass itself to affect the heart. But again, never say never. What it could be is the stress of undergoing any sort of treatment. And like we were discussing with Rose, folks that have peripheral arterial disease, they often have coronary arterial disease or central arterial disease. So it could be that the stress of any sort of procedure really does bother your heart. And that's something that should be examined prior to any other treatment for your axillary bifemoral bypass.
Okay, and Darlene has a question. You want to unmute Darlene?
Hi, doctor. Last fall I was diagnosed with PAD and I had an angioplasty in both legs. The doctor opened up blockages in my thighs and also below the knee. So since then, the below the knee has stayed open, but my thighs have blocked again. And I'm kind of an unusual case because I have no risk factors at all. Right now, my LDL is 30 and my HDL is 46. So I'm kind of on the fence on whether I want to get stents put in. And I'm curious, like, my right ABI is 0.8, my left ABI is 0.71. I'm on the fence on whether I should just kind of walk through this pain and build more peripherals, or should I go for a stent? I'm kind of worried that that's opening up a Pandora's box of repeat stenting.
Yeah, well, Darlene, that's a great question. It's
Yeah.
something that confronts folks every day. What to do, when to do it, why to do it. It sounds like, and I don't, again, want to give out medical advice. It's not the right forum. It sounds like you're having claudication. Is that accurate? Your
Yes.
legs hurt when you walk?
Yes.
Okay. Now, this is what I was talking about with Kim. It becomes a very nuanced discussion, a very detailed discussion with whoever's going to do any sort of procedure on you. What benefit do you stand to gain? And I would encourage you to talk to more than one doctor about this. I think
Okay.
getting a second opinion is very important. Doing things like walking more in the interim, always good. And when I say walking, again, back to that discussion about surfing or mountain climbing or karate, whichever gets your legs moving. And then, you brought up your risk factors. The classic risk factors for peripheral arterial disease are, like you said, high cholesterol, but then there's also high blood pressure, smoking, diabetes, and kidney disease. Those are the big ones. And I see you shaking your head. So if you have
I have none of those. None of
Oh.
those. No.
That's good. I mean, it means your prognosis is probably better than the person that does have those troubles. But again, talk to somebody else maybe. And
Okay.
I'm sure Kim is a great resource. You have navigators that can help you with any sort of challenge associated with finding somebody to talk to you about this in your local region.
Yeah, our philosophy always, especially with a high, at the higher end on the ABI, is walking is the best medicine. And we do have our walking program, and we do have walking materials that we can send you. If you email me, or I can KYM at thewaytomyheart.org, KYM at thewaytomyheart.org. They can put it in the chat as well. Email me, and then I can email you some great resources. Dr. Anita Dua, who's a vascular surgeon, she's on our board of directors. She's with Mass General, and she put together a great video on how to walk effectively to grow those collateral vessels and to improve your claudication in a very short time. And we do have our walking program that it will help you to track your steps and your improvement in walking over the course of a few months. But I agree with Dr. Zarkowsky. Everybody should have a couple of different doctors in the back pocket to weigh all of your different options. And especially if they're talking stents, the two of us were talking about the less is more approach, a leave nothing behind. And if a doctor is automatically saying to you, hey, we're just going to go in and place stents, that's not the right approach for anyone, unless it's definitely in the heart or in the abdomen. Even the iliac arteries are usually a guaranteed stenting if in fact they go in. But with the newer technology like lithotripsy, they're using stents even there less and less. Or is it still always stenting in the iliacs if they go in?
Yeah, another new technology for our friends that were interested in technology. Intravascular lithotripsy has become a very important part of our armamentarium when we're treating vascular disease. And the concept here is that it basically dissolves the calcium or makes it a particulate rather than a rigid rock, and gives a lot of that lumen back for blood flow. And so that is, yes, something that people are doing without stenting in the iliacs. I will tell you that it is another below the knee option. I have several patients that I've treated below the knee with Shockwave, and that's worked well for those folks. I know that there's a second company that's coming out with technology for intravascular lithotripsy, and they are not yet to market, but hope to be soon. I think they're undergoing their 20-center clinical trial to prove efficacy.
Yep. And so there's also and I'm just curious from your perspective, when I talk to patients about, when they say that they don't have any sort of risk factors, I always ask, about, well, what have they figured out the morphology of the plaque? Is it, rock hard calcium, or is it clot? Because if it's something that's clot, you're considered more hypercoagulable versus necessarily peripheral arterial disease.
Yeah.
Kind of what, Deion Sanders, Coach Prime, the former NFL football player, now college football coach, he's considered more hypercoagulable because of clots. Now, there are a lot of ways in which you can become hypercoagulable. It could be a genetic risk factor for a clotting disorder. You might have AFib. I don't know if you've ever had your heart checked for AFib, or for valvular issues, or even
my heart is totally
aneurysm.
clean. My heart is totally clean. I had all the heart tests. This is only happening below the waist.
And so, do they know if it's blood clot, or if it's
it's strictly plaque? The doctor who routed me said it was all plaque.
Oh, so he's already been in there.
Yes, I had an angioplasty, but I had angioplasties last fall, and the lower part below the knee is still open, but I'm blocked again in my thighs at the same spot where she had to really kind of chisel away because I was like 100% blocked.
Oh, but now you have a pretty high ABI at the moment, so you must be walking.
I have a lot of collaterals because I used to walk a lot before, and so
yes.
Yeah, I mean, my ABI is pretty high for somebody who's as blocked as I am. And is that a dangerous thing to be like walking around with a blocked main artery like that? I can't hear you.
Is this a mute button?
Yeah.
Okay.
All right, now I think we're. How about now?
Yeah.
Can you hear me now? Okay, wonderful. Yeah, so people do often wonder if walking with a blockage is a dangerous thing. And I would say, do what your body tells you.
Yeah.
When your body tells you, oh my gosh, it hurts, you stop, take a rest. So that's the classic description of claudication. So no, to answer your question.
Okay. Thank you so much.
You're welcome.
You're welcome.
Any other questions? We only have a few more minutes.
Can I ask question? Can I ask question?
Sure, Vlad. We actually asked your question earlier, but since you're on, go ahead, and you can ask it again.
Well, I think I have peripheral arterial disease because for last 3 months when I walk, I feel cramps in my legs and pressure in my legs, which just comes and goes. My test for arterial lower bilateral proximity was inconclusive, but can I say what happened through my heart test because it's related to PAD? For doctor, it's important to know.
Yes, coronary disease is related to peripheral arterial disease. That is true.
So I recently have heart CT angiogram with contrast, and they reveal, I have that paper with me, but they reveal some stenosis and some 30% calcification.
Sure. Any sort of treatment for the heart really does depend on symptoms. And so I am not a cardiologist, so I cannot really comment on central arterial disease, coronary arterial disease like you're describing, but certainly that's something that a lot of the folks that treat peripheral arterial disease also have knowledge of when they are cardiologists. And
so I think I have PAD because of that. So my point is, besides walking, what I do anytime because I don't drive, besides walking, my regular doctor sent me for like exercise center, but I also know some exercise can hurt. So which one correct exercise besides walking should I do in this situation, if I needed to do at all?
I would say that I would never overrule another doctor's suggestions. And so I would recommend that you have a very in-depth conversation with your doctors, describe what your concerns are, describe what your test findings are, and then really come up with a personalized plan for how best to help you.
But what's your advice? What's your opinion?
So earlier we were talking just in general, because I had asked your question in general earlier. I thought you were on, and you must have dropped off and came back. But we were talking about, the fact that you just have to move, whether it's swimming, cycling, surfing,
yes,
whatever
I
it might
know.
be.
I know I walk anyway because I have to walk
Good.
because I
Good
don't
for you.
drive. But my point is, if doctor send me for additional exercise to exercise center, do you know, first of all, do I need to do that? And what kind of specific exercise would you recommend? That's what I want to know.
Okay, so that's exactly what we're commenting on. And Dr. Zarkowsky can't give you specific medical advice on your situation because he doesn't have your medical history in front of him. But what we had talked about is if you are going to a gym and the doctor did in fact send you to the gym without any specific equipment to use. Number one, there are a lot of studies for walking. Walking is the best medicine for PAD and to grow those natural bypasses. But he was also talking about cycling, and there might be the elliptical that you might want to jump on. There are all kinds of different things, but the key is to exercise. And I know what's great about you, Vlad, is that you're always out there walking, you're always out there moving, and that's a really good thing. And I'm really impressed that you are fighting through it.
Well, I need to know specific in this exercise gym place. If what should I do, or what should I not do? Basically, that's what's my question.
What I would suggest you do there is I would talk to the gym in particular and ask them if they have a physical trainer that can meet with you and do a session with you and show you the different devices inside the gym. And he can work with you on those, the different constraints that you might have or any limitations you might have. And he can also provide any safety precautions that you might need in using any of the equipment inside their facility.
And Kim, I know you have a new initiative with the Weight of My Heart. That's a walking dashboard for
Can I ask a question?
do folks get an opportunity to be diverted geographically to gyms that will support this walking program?
And so what we do, so the My Steps walking program is available for anyone right now in the US. We are going to be expanding globally, and it's a remote program. So most of what you do is tracking at home. But if you do go to a facility, you can actually get on a treadmill and you can track your steps manually on our particular system that we have. And you can go to padhelp.org. And there's information on the My Steps program that's on the website. Or again, you can email me at kym@thewaytomyheart.org, and I can send you more information. But, first and foremost, our program is not a replacement for supervised exercise therapy or a SET program. If your facility has access to a supervised exercise therapy program or a cardio rehab program, we 100% will tell you to go ahead and do that. If you have the transportation, you have the ability for co-pays, and they are working with your doctor on your goals for improving your circulation. But with our system, it's for many people who don't have access to those set programs or those formal supervised exercise therapy programs, because there's so many obstacles for people having access to them or being able to participate or to be able to be consistent. It could be financial, it could be transportation wise, it could be time wise. We find that, there isn't that much adherence to those programs because of a lot of these obstacles. And so that's why we started our structured program, which allows you to just use your own phone, your text, to be able to track your steps and get the accountability that you need to walk as much as your doctor wants you to, whether it's 30 minutes a day, 45 minutes a day, or 60 minutes a day, depending on your presentation of disease. And then you have access to the dashboard, and also your doctor has access to the dashboard and can pull up your progress and help to monitor you as you
Can I
go,
just ask?
through your journey.
Can I just ask opinion of a doctor about my legs to conclude my question?
Sure.
So if I have calcification, they find like 30% calcium score in my heart with some stenosis, but my test on a leg, arterial test, doesn't show anything. Would I still have PAD, in your opinion?
In all likelihood, you do, but without knowing your history, again, it's very hard for me to answer
My
that question.
history very short. My history very short. It starts 3 months ago. Cramps and pressure in legs comes and go when I walk. And then we did these 2 tests. Arterial, low extremity, doesn't show anything, but heart show calcification and stenosis.
Vlad, if you send us an email offline, we can certainly help direct you. But I think it's really going to be a conversation that we have to have offline. If you send us an email, we'll make sure you get connected appropriately. Okay.
Okay.
Thanks so much, Vlad.
Hello.
There were a couple other questions. Eli, you had a question for the doctor?
Yes, you know what the question is. I'm having this procedure, what to expect during and after, and what's the recovery?
So she's having an endovascular procedure.
Okay.
And so she wants to understand, what is the process for an endovascular procedure for the legs?
Okay, so an endovascular procedure for the legs. And what sort of setting are you having it in, Eli? Is it going to be in a hospital? Is it going to be ambulatory surgery center?
So actually, this is interesting.
Yeah.
Just before we started here, I was texting with her doctor because they were supposed to do it tomorrow, but there was a little scheduling snafu. She was going to have it in the hospital, but the doctor feels like he has more tools available at his discretion inside the office-based facility.
Sure. Okay. Interesting. Oftentimes in hospitals, there are committees that really dictate what you can and can't use in the hospital based on reimbursement from insurance. Once again, one of those bugaboos we talked about earlier. So in an office setting, I expect that it will be a fairly easy, convenient, and efficient experience for you, Eli. If you were coming to Fallbrook, to my practice, generally there's only 1 or 2 people in the waiting room when you show up. Those are the other patients that I'm going to see either before or after you. You'd be greeted by my front office staff. They'd give you something to read for a little while and then maybe some forms to fill out. That'd be about 15 minutes of your time. And then often folks go back to the pre-treatment area. You get into a gown. I give folks pants so that they don't have to walk around without pants on. And then, it's really about 5-10 minutes from there that we take you back into the office-based lab. In my particular office, I don't use any sort of sedatives or opioids. It really gets in the way of the patient being able to communicate with me. And honestly, it's something that just local anesthetic seems to be enough for folks that come to my office-based lab. And so once I have a person comfortably situated on the procedure table, I do use an ultrasound and I put some local anesthetic into the area where I will start treating the artery. And from there, it can be 30 minutes to an hour and a half worth of working time for me to take care of the arterial problem in the leg. Generally, at the end of the procedure, I use something called a closure device, which seals up the artery. Usually give you a little bit more of local numbing medicine so that you've got a bit on the way to the recovery area. And then folks that I treat generally have about 2 hours of just laying, watching some TV, talking to the family member that's brought them to the office. And then after that, we walk you around. We make sure that there's no issues with the way the artery was closed. You might have some new medicines that my staff will talk to you about when you go home. And then those prescriptions will be waiting for you by the time you get to your pharmacy. And then generally I will see folks back a week later. I'll give you a phone call the day after, me personally, just to see how things are going the day after. And then I'll see you a week later And then generally ultrasound somewhere between 2 weeks to 4 weeks after that procedure to really get an understanding of how our treatment, how effective it was. And so that in broad strokes is the workflow for my office.
Does that make you feel more comfortable, Eli?
Take me a second to find the right button. Yes, and what's the recovery then after that?
You're
I
walking
mean,
2 hours after the treatment.
no, but I mean, how is how is it going to affect the pain level in my foot? Is it,
Ah.
yes.
Well, so the pain that you're feeling in your foot is really from nerves not having enough blood flow for a long period of time. And that particular aspect of your recovery is highly variable. I have somebody that I'm thinking of that I'm going to see in about a week or two who, she had a complete blockage from groin to really the ankle. And it took a good year for her pain to go away. Now, folks with less severe blockages, less time with nerves not receiving blood flow, the recovery would be quicker. Rarely will it be immediate. I would say most people are in for about a month more of discomfort, which gets better with time. But when it's rest pain, and what you're describing is rest pain, that really takes a bit of time to get better.
And well, how about being frozen cold all the time? Well, my foot starts feeling warm without a heating pad.
right away, right?
Yeah, no, your foot will be the best situation is when we call it a hot foot. When right at the end of the procedure, we notice that the foot is bright pink and it's got a lot of more blood flow through it. That's a great result, and that's what we hope for every time. So I'm hopeful for you that you have
I'm
that.
hoping your feet are warm right after the procedure, Eli. I want that call and say, my feet are warm.
Oh, wow, that would be such a treat. Thank
That
you.
would be. You're welcome. Unless
We have,
they,
we have a question about collaterals. Can collaterals block? And can, that was the question.
Can collaterals become blocked?
Yes.
Is that the question?
Mhm.
Yes, of course they can. Yeah. And that is a challenging situation. And it can happen for many different reasons. Progression of plaque, and it can also happen because of clot going down the arteries. But there are many reasons that collaterals can be blocked, and that is a challenging situation.
And Douglas, are there any more questions that are coming in on the chat, or that they want to jump in and ask before we wrap up here? We
Hey,
lost your
Kim,
mic.
I've got one.
Okay, that's Alan?
Yeah, I actually got done with PT and here I am.
I love it.
Just a quick question for my right leg is just basically running off of collaterals. What's the lifetime of collaterals? Is it a permanent fix, or if you keep exercising, can it be a lifetime fix for that leg?
Short answer is yes.
Okay, that's all I do.
Yeah.
Thank you.
Keep walking. Glad you're back from PT.
Hey, Kim,
I
I
have
got a
another one.
question.
Yes, Heinz.
Hello, Doc. Thanks
Hi.
for being on.
You're very
Hey,
popular
question.
today.
This is a broad
problem. I'm happy to
question. That with all the news hype recently on new research finding plastics in our blood system.
Yeah.
What do you think? Are we fighting a losing cause here with all the diseases we already have? Cardiac or PAD or whatever?
I would say, Heinz, it can't be good, but I can't give you a more discreet answer than that. I do my best to drink out of glasses and metal containers that don't have plastic lining. But as to whether or not it's a lost cause, I certainly hope not, because I intend to be here for about 50 more years at least.
Well, how
As,
about,
I hope we all are.
you get an IV, for example. What do they use generally for the IV? It's not glass.
No, it is plastic. Yeah.
Yeah,
That's an
so,
interesting
so
Use plastics and everything.
where are we going to? I know it's still in the early stages as far as I know on what they're finding, but I just wanted your opinion on that.
Yeah, no, Heinz, this is a very detailed discussion that, certainly send us an email and we can get into some of the literature that I know about offline. But yes, certainly a concerning thing for us modern folk.
And
Okay,
you
thank
were
you.
speaking about research. I was just Judy had sent me this article, and I'm not sure if you had a chance to check your email before you came here, but researchers have discovered that the smooth muscle cells that line the arteries of people with atherosclerosis can change into new cell types and develop traits similar to cancer that worsen with disease.
Well, certainly smooth muscle cells are what we're talking about, and those have been long known to change into what's called a foam cell after they ingest a lot of bloodstream cholesterol and fats. And that changes the characteristics of the cell and the cell function. And that is the origin of peripheral arterial disease, is that transition from smooth muscle cell to foam cell to fatty deposit to plaque. And that repetitive process is really what causes peripheral arterial disease, which brings us here today. That is mediated by a number of chemicals. And I think what they've done is developed a monoclonal antibody that short circuits this pathway and prevents it from progressing. And that's what I took away from that article. The word cancer being tossed in there, sure. I mean, it's something that resonates with people. But as to whether or not it really should govern the approach to peripheral arterial disease, I don't think it makes much of a difference. It's just good to have a new tool for us to help folks with.
Yep. And I
We
thought I
have
heard
a
one
que-
more in there.
We have a question from Marcia.
Yes, hi.
Marcia.
Thank you, Douglas. So we always hear that the best thing to do is walk, walk, walk. And as somebody with OCD as well as PAD, I went crazy, kind of like Nancy. I'm doing I'm between 16, 20,000 steps a day. But I wonder if I'm doing more damage maybe to my joints and other things. I'm going on Medicare this year, so I'm about 65. How much is too much? How much is enough? Does it depend on, if you're going from 0 to, 100 overnight? So that's my question.
Yeah, no, great question, Marcia. Thanks for asking it. I certainly think that anybody undertaking new exercises should really talk with their physician about what exercises are appropriate, because we all have different health challenges that I can never hope to guess. So I don't want to speak out of turn here. But in general, from a walking standpoint, Kim, I think, as you said before, it's the best medicine. And I can't really give you a number that would be too much for anybody. I would say, Marcia, that 16,000 steps is commendable. Good job. Keep it up.
Marcia's been amazing. She was actually up for, Marcia, do you mind if I mention?
Oh, no, go ahead.
She had a couple endovascular procedures. Her thigh she's one of those that just has a very fast healing response. So she plugged up a couple times. They said, no, we're not going to do another one. This was an interventional cardiologist. He's like, no, I'm referring you to vascular surgery. Let him make the determination. Went to vascular surgery. And in the meantime, between those appointments, Marcia and I, we worked on, walking and pushing. And she gets there, gets the ultrasound or a CT scan done. And the doctor's like, I don't think I need to do anything. You've grown enough collateral vessels that I think you've actually created your own natural bypass.
Wow.
And I was really impressed, and you've been doing great. And you're actually living proof that you can grow those natural bypasses.
Yeah, but the worry is, how long can you keep it up? If the collaterals will diminish, if my activity diminishes, that's the problem.
Yeah, that's actually
concern.
A problem. And is it affected? So let's say, and God forbid, someone falls, for example, my dad ended up he ended up falling, and then his walking diminished, and, so he's not walking as much. So the next thing is his heart ends up blocking up again. And that's a concern for some of the patients, that as they age, they're just surviving on collaterals. The doctor says, no, we're not going to do a procedure. And then it grows into these long calcified lesions that become tougher over time. Whoops, we just lost you over there. Sorry. There we go.
Got a bit of wind here.
Yep.
Yeah, so Kim, I think what you're...
Hold on. Oh, there you are.
So Kim, I think what you're really driving toward is, the close collaboration between specialists for different reasons.
Mhm.
And what I heard you talk about is the heart and how the legs affect the heart. And certainly part of any sort of heart treatment involves cardiac rehab.
Yeah.
And that's another reason I treat intermittent claudication is there's a lot of folks that have a need for heart revascularization that cannot complete cardiac rehab because their legs hurt.
Mhm.
And so treating claudication in those patients is very important so that their heart, which is a very important organ, can be appropriately treated. And so collaterals, yes, they are robust and they can support the function of a leg around a blockage. And yes, it is concerning that as you age, you might not be able to motivate them in the same way, but most likely you've done enough in your young age that when you do get to the point where you can't walk as much and can't do 16,000 steps, you'll have formed enough pathways for the blood to support the function of your legs, regardless of how active you can be.
Whew, I think that's a good note to end on. What do you think? That was a very positive note. Lots of hope there. I want to use this moment to thank you so much. Congratulations on your new office space facility here in the San Diego area. I wanted to present to you our brand new official PAD bracelets. And these
Awesome.
are made by Robert Castleberry, and they're
Put it on right now.
Yeah, we would love that. I want to make
Okay.
sure it fits. And these are handmade by a PAD warrior out of Georgia, Robert Castleberry. He has a YouTube channel, Pad Life Outdoors. And if anyone wants one of these bracelets, the money actually goes to charity. It goes to the Global PAD Association. And you can get one and you can email me at kym@thewaytomyheart.org and I can tell you how and put you in contact with Robert. But thank you so much for all of your time and for dedicating so much to our patients here. Any final words, any last pieces of advice to share?
You're all such well-informed folks. By taking the steps to control your own PAD destiny. Keep it up.
Thank you so much, everyone. We really appreciate you joining us. And if you want more information, we're going to be doing this every single week. It's going to be What's Up Doc on Tuesdays. It'll be a different time depending on the doctor's schedule. I'm sure we can convince Dr. Zarkowsky to come back and join us on another Tuesday. But we also have on Friday, we have our Foodie Friday. So we're going to be doing a cooking demo this Friday. It'll be live. Same that channel. It'll be at 2 p.m. Pacific time on Friday, 5 p.m. Eastern. So make sure you join us then. And we'll see you also next Tuesday. Not sure who the doctor is. Maybe we'll invite Dr. Zarkowsky back.
No problem, Kim.
Thank you so much, everyone, for joining us.
Take care,
Thanks.
folks.
Thanks, Kim.